Mag-start na ako. Good day, everyone. Welcome to the Rationale of our Week 7 quiz. I am Vincent and Purpose, your lecturer for today. So, question number 1, which of the following etiologies of hemolytic anemia are considered acquired extrinsic condition except? So, we have option letter B, which is condition that exposes erythrocyte to extreme temperature. So, that would be under the thermal injury. Next, we have option C, the presence of cold antibody, in which it is under immune hemolysis, presence of cold or warm autoantibody. And letter D, patient with prosthetic heart valves, which is considered an intrinsic acquired condition. So the correct answer for this question would be choice letter A, in which the condition in which there is a defect in enzyme involved in the glycolytic pathway. So we know that we discussed about two enzymes that are essential in glycolysis, one of which is the enzyme for glucose 6-phosphate dehydrogenase. So this belongs, the G6PD deficiency belongs to intrinsic hereditary condition. That is why this is the answer for this question. Next, which of the following statement correctly describe acute hemolysis except? So, based on page 317, in acute hemolysis, it is usually rapid onset and maybe episodic or isolated and paroxysmal. And a good example of acute hemolysis is HTR or hemolytic transfusion reaction. So the best answer for this question is letter C, in which the bone marrow can well compensate with the insult. Usually, this statement is more applicable to chronic hemolytic anemia because even though there is reticulocytosis in acute hemolysis or acute hemolytic anemia, the bone marrow cannot well compensate with that. So, mas maraming compensation yung mangyari during hemolytic or during chronic hemolysis. So next question, the following are correct regarding the measurement of CBC with patients with significant hemoglobinuria except. So this question was corrected. There are two possible answers in here. We have routine CBC are still reliable even in the presence of significant hemoglobinuria, and hemoglobin level determination is not affected. So ito yung possible answer dalawa. Because during significant hemoglobinuria, our routine CBC are unreliable and our hemoglobin is very affected because it could be falsely elevated during significant hemoglobinuria. Because when we have significant hemoglobinuria, it also means that we have significant hemoglobinemia. Because kung ano yung present sa blood natin, makita din natin sa ating urine. And tama itong option na MCH and MCHC are greatly affected because nga, kung affected yung hemoglobin natin, maapektuhan din yung RBC indices that utilizes hemoglobin in their formula. That is why correct regarding significant hemoglobinuria except is routine CBC are reliable in the presence of significant hemoglobinuria and hemoglobin level termination are not affected. So sila yung mga false statement dito. Next, which of the following statement correctly describe development of anemia in cases of hemolytic anemia except? So, in healthy individuals, the aged RBC are removed extravascularly, which is very correct. I emphasized that in the lecture. When the quantity of the RBC that are prematurely removed into circulation exceeds RBC formation, anemia can develop. Yes. Option letter D, levels of haptoglobin and hemopexin are not usually affected during extravascular hemolysis. Why? Because in extravascular hemolysis, hindi tayo gumagamit ng haptoglobin and hemopexin usually. Usually, the haptoglobin and the hemopexin are usually yung magamit talaga siya during intravascular hemolysis. Kasi di ba, your haptoglobin or your hemoglobin attaches to your haptoglobin for it to be reused or para magamit siya sa ibang processes. And then your heme portion of your hemoglobin will attach to hemopexin. Kasi di ba, heme is very toxic to the body. So kailangan niya ng carrier protein para hindi siya mag-deposit sa tissues. So the best answer for this question is option letter C because normal removal of senescent damaged RBC occurs extravascularly, not intravascularly. So the answer for this question is letter C. Next question, the following laboratory results are observed during intravascular hemolysis except. So as you can see here in figure 20.6 on page 327, so we can see here that there is increased fecal urobilinogen and increased urine urobilinogen, which is option letter A. There would be increased LD2 because um, in the RBC we can see or we can have LD there, and then we could have hemosideриnuria. For option letter C, this is the incorrect statement because it should be increase in unconjugated bilirubin. I mean, unconjugated bilirubin is increase in intravascular hemolysis. So hindi tayo dapat makakita ng bilirubin in the urine during intravascular hemolysis. As you can see here, urine bilirubin is negative in here. So if makita man yung bilirubin dapat sa urine, it should be in the form of conjugated bilirubin or in the form of urobilin. Next, what is the expected haptoglobin and hemopexin level in increased intravascular hemolysis? It's simple. As you can see here, the hemoglobin will attach to the haptoglobin and the heme will attach to hemopexin. If there is increased level of intravascular hemolysis, so there would be increased release of your hemoglobin and the release of heme. So the haptoglobin level will be eventually exhausted, same as with your hemopexin. That is why the correct answer for this question would be decreased haptoglobin and decreased hemopexin level. Next, which of the following tests provide good indication of the bone marrow compensation via accelerated accelerated erythropoiesis? Based on your RODAC, page 331, the reticulocyte count is the most commonly used to detect accelerated erythropoiesis and is expected to rise during hemolysis or hemorrhage. That is why your retic count is your good indicator for bone marrow compensation. Glycated hemoglobin or your HbA1c is usually used to monitor blood glucose level up to 2 to 3 months. Prior, mga 2 to 3 months. So, X yan siya. Lactate dehydrogenase level, not much. So, the best answer for this is your retic count. Next question. The following statement correctly describe hereditary spherocytosis except. So we have defect in SPTA1 and SPB leads to abnormal spectrin, yes. Nandun yun sa PowerPoint. Deficiency of one of the 5 proteins, yes. RBC in AHS have decreased surface volume ratio, thus assuming spherical shape. Diba, nakita natin doon, kaya nga increase ang kanilang OFP kasi decrease yung kanilang surface area to volume ratio. So the correct answer for this question is option letter C, in which the spherocytic cell passed to the splenic sinusoid. So what makes this statement wrong? Kasi meron nakalagay dito with ease, thus resulting to splenic trapping. Kaya nga sila mas matrap sa spleen because mahirapan sila makapass through to the mga masisikip na sinusoids kasi hindi sila deformable. So the best answer for this question is letter C. So based on the image below, So based on the image below, what is the concentration did hemolysis happen and interpret the result? So you all know that in this OFT or osmotic fragility testing, this is to diagnose hereditary spherocytosis. So very bonus question na ito, no? Kasi alam nyo na it's 0.65 kasi 0.90, 0.75, no hemolysis pa dyan. And then at 0.65 na concentration ng sodium chloride solution, there would be meron na siyang slight na tinge ng color. So yan na, alam nyo na it's either dito na lang. Alamin nyo na lang is increased ba or decreased ang OFT. So nakita nyo dito na illustration on your right side, Normally, dapat decrease yung osmotic fragility. Dapat at 0.45 pa siya karoon ng hemolysis. So, in patients with hereditary spherocytosis, at 0.65 pa lang, which is malapit pa siya sa normal saline solution na concentration, nagputok na yung red blood cell. Kaya, increase ang kanyang OFT. Kasi di ba, OFT is osmotic fragility. Di ba, you know that in hereditary spherocytosis, meron silang decreased surface area to volume ratio. So kahit slightly hypotonic pa lang yung solution at 0.65 na concentration ng sodium chloride, pag magpasok yung water dito, magputok sila agad. So mas fragile sila when compared to normal red blood cells. That is why the correct answer for this question is 0.65 concentration with increased OFT. Next question, which of the following statement describes H. pyropoikilocytosis except? So the correct answer would be increased level of calcium and sodium intracellularly because I mentioned that it's only calcium that is increased in hereditary pyropoikilocytosis. So tama naman 'di ba itong there is presence of membrane loss and rigidity that's affecting deformability, and then cells fragment at 45 to 46, and then yung normal cells usually fragment at 120.2 Fahrenheit or 49 degrees Celsius. So, i-convert ko lang siya. So, the best answer for this question would be letter B, increased level of calcium and sodium intracellularly. Kasi dapat in this situation, increase lang yung calcium intracellularly. Sige. Next, the following statements correctly describe hereditary stomatocytosis except. So, option letter A, increased permeability to sodium and potassium resulting to influx of water into the cell, which is correct. Letter C, absence or defect in band 7, which is correct. Ayan. And then this is also called overhydrated hereditary stomatocytosis or OHS. So that leads us to the correct answer is letter B, efflux of water. Kasi dapat influx ito, hindi siya efflux. Papasok dapat yung tubig. Kasi 'di ba? It is also called overhydrated hereditary stomatocytosis. So dapat papasok yung water, hindi palabas. So kung ito yung RBC, influx dapat, hindi siya efflux. So hindi yan siya palabas. Kasi pag efflux na siya, yun na yung spherocytosis. So ito na yon. Describe spherocytosis except. So in here, the potassium efflux is greater than the sodium, tama. There are stomatocytes and target cell, tama. Nandito yan siya, stomatocyte, target cell. And then, decrease MCV and increase MCHC. Nakalagay dito, decrease daw yung MCV niya and increase MCHC. And so that, it leads us to letter D, increase OFT. Kasi in hereditary spherocytosis, it is usually decrease osmotic fragility testing. Okay? Next, the following are clinical manifestation of Abetalipoproteinemia except. So, ang tinanong natin dito, it's the clinical. So, retinitis pigmentosa, correct. Mental retardation, correct. Ataxia, correct. Pero, tanong kayo, sir, bakit mali man itong presence of acanthocyte in the peripheral blood smear? Then, go back to the question. The question is clinical presentation. Clinical ba ito? Hindi. This is a laboratory finding. So, itong tatlo, ito lang yung clinical dito. Yung laboratory finding, yan yung presence of acanthocyte in the peripheral blood smear. Next, ito, 4-year-old, 9-month-old baby with a history of hyperbilirubinemia during newborn period with no apparent cause. No family history of hemolytic anemia or parental consanguinity. He presented prolonged neonatal jaundice and severe anemia requiring RBC transfusion. An intake of ding-dong crackers, 48 hours onset of symptoms was reported. So what would be the possible diagnosis for this case? So alam natin na hemolytic type of anemia ito. So anong significance ng ding-dong? Bakit may picture ng ding-dong dito? So if you are familiar with the ding-dong, kita nyo dito, meron silang caution. Snack mix contains fava beans. So ano yung mga na-mention natin na may fava beans doon? So, di ba, pag ang patient is having glucose 6-phosphate dehydrogenase deficiency and then they are exposed to fava or yung may mga alfalfa beans such as your dingdong, they would develop favism that is manifested in glucose 6-phosphate dehydrogenase. So that would be the answer. Next, so what are the expected laboratory result of G6PD? So in table 21.6, so nandoon hemoglobin of less than of 4 grams per DL, which is interpreted as decrease in hemoglobin. There would be decreased haptoglobin level in here, indicators of hemolysis. There would be increased lactate dehydrogenase, tama din. There would be hemoglobinuria, tama din. So, ang mali dito is yung D80 kasi dapat D80 negative sila. And then, dapat dito is increase lang yung indirect bilirubin. Kasi di ba during G6PD, mas madami yung intravascular hemolysis than your extravascular hemolysis. So this is the correct answer. Hemoglobin, decreased haptoglobin, increased LDH, and hemoglobinuria. So don't skip yung mga tables sa RODAC because very important yan sila. Next, what is the expected level of NAD-PH and amount of fluorescence in G6PD deficient individuals? So, di ba nakita niyo to sa PowerPoint, ito, the glucose 6-phosphate plus NAD-P. In the presence of glucose 6-phosphate dehydrogenase enzyme, your NAD-P will be converted to your NAD-PH, which is a fluorescent chemical. So if you have increased G6PD activity or normal to increased G6PD activity, so mas madami yung NAD-PH na increased NAD-PH na formation, thus increase din yung fluorescence. So ang sagot dito, deficient man daw. So meaning, baliktarin nyo lang, decrease yung NAD-PH and walang fluorescence. That is why ito yung sagot sa question na ito. Kasi yung tanong natin, it's the deficient individuals. Next, a case of 50-year-old female presenting with proteinuria, corneal opacity, and anemia. Which of the following lab tests correlates with your diagnosis? So for you to be able to correctly answer this, you should know the diagnosis. So this manifestation is very typical sa Abetalipoproteinemia, which is an autosomal recessive disorder. So ano yung effect nito, di ba? Wala daw silang triglyceride and cholesterol are decreased. So tingnan nyo, triglyceride and cholesterol, so HDL is a cholesterol, so tama. Decrease ApoA1, A2, and B, di ba? In your clinical chemistry, this comprises your HDL. So, decrease din. And then, normal RBC indices daw siya. That would categorize Abetalipoproteinemia as normocytic normochromic type of anemia. So, tama ito silang tatlo. Next, two sisters named Len, 9-year-old, and Sarah G, 15-year-old, have been under the care of Dr. Kim Pang in the OPD of Baby M Hematology Clinic since birth due to hemolytic anemia of unknown etiology. The older sister have been transfused 67 times due to prominent anemia with jaundice. At the age of 9, she underwent partial splenectomy, and after which the frequency of transfusion could be reduced, but only transiently. Second sister presents similar clinical features of severe hemolytic anemia. They have been hospitalized 21 times for 21 pack RBC transfusion. What are the expected laboratory results for this case? So for this case, this is a case of your, I think, PK deficiency. So, malaman nyo na bakit siya PK deficiency because they require multiple blood transfusion. So, nakalagay dito, they have variable amounts of hemoglobin. Tama. PBS shows poikilocytosis. Then OFT is normal. Tama. And then, ayan osmotic fragility is usually normal. And there is increase in direct bilirubin. So, ang mali lang dito is your D80 positive kasi hindi naman siya antibody mediated. So, di ba, defect siya sa intrinsic. So, mali ito na sagot. So, ang tama lang dito is variable hemoglobin, PBS with poikilocytes, OFT normal, and increased serum indirect bilirubin. So, yung case na ito, yung pa-diagnose dapat kayo, gibonus na lang. So, tinanggal sa number of items. That makes 28 items. So, next, a 4-year-old. Ito yung kanina. Tama ba ito? 4-year-old. Oh, tama. For long neonatal jaundice, di ba ang diagnosis natin dito is G6PD deficiency. So, if you've read your book, makita niyo dito, this confers protection against life-threatening Plasmodium falciparum malaria. So, this is the answer, Plasmodium infection. In patients with G6PD deficiency, somewhat resistant sila to Plasmodia. Next, which of the following hemolytic anemia require treatment except, di ba sabi natin sa discussion natin, hereditary elliptocytosis usually do not require treatment. This can be seen on page 344. So, that ends the rationale. If you have any clarification, please don't hesitate to contact me on the Telegram chat. Thank you and God bless. Study well.